Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. I hope everyone's doing well today. We are now into May, and I can't believe how fast this year is going. I mean, it just absolutely has flown by, and we are almost into summer. So we are going to enjoy this next month of some spring weather, hopefully. I think it's been so cold, we really haven't had a chance to do that. So, and I'm hearing me whining from Southern California. For us, cold out here is anything below 60. We're like, boy, it's cold. But it's been nicer lately, so we're excited about that. Our CodeCast topic today is going to be Transitional Care Management. The acronym is TCM. Mostly out of necessity. I presented a webinar a couple weeks ago on transitional care management and chronic care management. And the questions I got after the fact and some of the things that I'm seeing some of the vendors do out there, it's actually steering practices in the wrong direction. And this topic not only has compliance red flags all over it if you don't do it correctly, but because it's a revenue generator, you have to make sure you're following the rules of CPT and Medicare. Otherwise, you could find refund requests and also pretty upset patients. Transitional care management is actually a very, very good service, just like CCM, and I did a podcast on that last year. But we want to really just take a look at it for what specifically it is. And sometimes I think staff can be blindsided sometimes and told, hey, we're going to start coding for this without any direction at all. I've had several practices that say, hey, my doctor says we need to start coding for this service. How do I do it? And I'm thinking, okay, wait a minute. Before you code for anything, first you need to discuss it with your team and say, this is why we want to do this service. We are finding that we have this class of patients or this population of patients who are in need of this service. So the first thing we need to do is let's talk about that population of patient. And then we go through and say, okay, here are the coding options. Here are the revenue opportunities. Here are the rules. And then you go and figure out, is this something that we want to code for? Not basically get it put on your desk Monday morning and say, we're going to start coding for this. I can't tell you how much that drives me crazy. And so what I want to do is give you not only this potential revenue opportunity, but also the rules so that you find that you're not looking at refunds or potential non-compliance within the code, and that you have good information so that you can bring it back to your practices and say, okay, maybe we should do this, or hey, we had talked about doing this and I don't think this is for our practice based on our patient population. So we're going to take a look at that. But first, the CodeCast podcast is also brought to you by Better Living. Since 2002, Better Living has been the premier digital lifestyle brand dedicated to travel, food, health, home, and more on betterliving.com. Okay, so when we look at transitional care management, it's an interesting concept because I think that when I first saw it come out a couple of years ago, it's only a couple of years new, I really believed it was for the primary care physicians and not really specialty physicians. But I've seen in recent months and even probably in the last year that a lot of specialty physicians like cardiologists, gastroenterologists, pulmonologists seem to do this quite a bit. They've really jumped on the TCM bandwagon. But to do that, you have to make sure you're really understanding the concept. Otherwise, you could be billing for something that you're really not entitled to. And the rules say only one physician in a 30-day period from the time the patient is discharged can bill for the services. And so let's take a look at what is transitional care management. So the codes are for new and established patients whose medical and or psychosocial problems require moderate or high complexity medical decision-making during transitions in care from inpatient hospital setting, partial hospital, ob status, or SNF to the patient's community setting. So if they're going home or the rest home, or they call it domiciliary living or assisted living, not SNF. They can't go from hospital to SNF and pay for this, but they're going out into their community. Basically, they've been inpatient for a couple of weeks or longer, and they need help transitioning into being on their own with little or no help. And so somebody has to be on the outside helping them coordinate their care. And so TCM, so Transitional Care Management, starts upon the date of discharge and continues for the next 29 days. So it's a 30-day code. And then we'll look at some of the administrative rules that are mandatory to bill the service codes. And when we're looking at CPT codes, if you get back to your office and want to look them up, you're looking at the codes 99495. That's Transitional Care Management with the following required elements: communication, direct contact, telephone or electronic, with the patient and or caregiver within 2 business days of discharge, medical decision-making of at least moderate complexity during the service period, and then a face-to-face visit, it's part of this service, within 14 calendar days of discharge. And then 99496, same as the above, except the medical decision-making is high complexity and the face-to-face visit is within 7 calendar days of discharge. Now you're looking at anywhere from $153 to about $216, depending on which code you're going to use. And so it's typically similar to an office visit charge, but probably a little bit more elevated, more towards a level 5 or possibly a level 4 new patient. But this is for new and established patients. But when you look at the transitional care codes, you have to understand that you have to qualify, meaning that a patient has to basically not have a caregiver or a family member or anybody that can help coordinate their care plan or their services, meaning pick up their prescriptions, schedule their appointments, and all of that. And it's not just schedule their appointment with their, let's say they were in the hospital for their slip and fall and they broke their hip. So it doesn't mean to just schedule an appointment with the orthopedic surgeon and post-op. It means making sure that you know if you're going to take on this service, that you're going to have that scheduled with their ortho, you're going to schedule their physical therapy if necessary, their occupational therapy, learning how to, daily living, possibly make sure that they're picking up, well, I shouldn't say possibly, this is actually for sure, making sure they're picking up their prescriptions or it is taken care of, and all of that. So it's not just a certain specialty physician service that you're following up on. You're coordinating all of the patients, basically all of their care from the time they transition out of the hospital for that next 30 days when they need help. Now, additional E&M services provided to the patient on subsequent dates after the first face-to-face can be billed separately, but that's for a different problem. And one of the main elements, or I should say support of these codes, is that medicine reconciliation and management must occur no later than the date of the face-to-face with the physician. And so either within 7 or 14 days. Usually it's sooner, but that is something that has to happen and well documented. When you code for these services, make sure that you can also support the administrative physician or nurse practitioner contact of the patient within 2 business days of discharge. If anything gets denied on these services, this is what CMS said when reviewing claims from 2016 and 17. They said reporting that many patients were either readmitted or there was no documented support of the TCM service, including that the contact was made within 2 business days of that original discharge. There was just no evidence that the patient was contacted either on the phone or by electronic means. And that means reciprocal effort. It doesn't mean that you left a message at the patient's house or home or on their cell phone or however their point of contact is. It means that you actually talked to the patient or their caregiver while the patient was present. And so this is really important to make sure that you get that reciprocal 2-day phone call taken care of. So the healthcare provider is accepting care of the beneficiary post-discharge for the facility setting, and it's really without a gap in care. So you're taking on the responsibility of the beneficiary's entire care. And not everyone qualifies for transitional care services. There is a specific patient here in mind with issues of moderate to severe problems along with mental limitations. And so that's why they have to be closely monitored. There are some third-party vendors out there that are encouraging random family practice physicians and general practitioners to obtain a list from the hospital on all discharged patients to take over their transition into their non-hospital community and bill for these services. And this is a compliance red flag. It needs to be the physician that is actually taking care of the patient. So the final policy adopted, and I can't tell you how many times I've had to send this over to these vendors, It says, we will pay separately for transitional care services of a beneficiary from care furnished by the treating physician to the care furnished by the patient's primary physician in the community. So again, you are setting up all of this coordination of benefits with that patient, and you're willing to assume comprehensive responsibility of that patient's care during that 30-day period. So a couple of things to note on these services. Only one healthcare professional may report the TCM service per beneficiary, and it has to be a physician or mid-level provider. Report services once per beneficiary during the TCM period. Now, the same healthcare provider may discharge the beneficiary from the hospital or inpatient facility and also bill the TCM services, but that's not going to be your face-to-face requirement. You actually have to bring them back into the office. These services are also subject to global post-op rules. So if there was a procedure billed with a 90-day global on it, you can't do transitional care for the same surgeon who provided that service. And then the patient also has a share of cost. So there has to be a consent, meaning that you're allowed to bill for this service, and that should be upon discharge. And that's why it's so important that you're that patient's physician that is now sending them into their community, because you would be getting, any kind of consents anyway, or it would be already on the chart because you were the one that admitted them. What you cannot report with transitional care codes: care plan oversight, care plan end-stage renal services, home and outpatient INR monitoring, those are the new codes, any online medical eval services, complex chronic care services, no medication therapy management can be reported as well. Prolonged services without patient direct contact cannot be reported. And then, of course, no telephone services, but we all know that. So here are some FAQs in case you do decide you want to take this on. What date is used on the claim form? This is a little bit controversial. 30-day period for the TCM service begins on the date the patient is discharged and continues for the next 29 days. So originally, the bill date should be the 30th day. Now, Medicare did come out in a Q&A, not a formal MedLearn Matters article, but in a Q&A on their website, and I really was not happy when I saw this. They said, well, if you want to, you can bill the date that the face-to-face was done. But I don't like this at all, because basically it's kind of like, to me, giving your kids their Christmas presents early and before Christmas Day. I mean, you know what happens on Christmas Day? They're still looking for another gift. And so you have to not do that. But it's the same thing here. And then you also run the risk of, let's just say you have a payer where you billed it on the 14th day because it was a moderate risk patient. That was the day of their face-to-face. And then they said, send us the paperwork. And it's only 14 days of service. They don't have a 30-day from discharge. I think you'll get some pushback from some of the commercial plans. The place of service on the claim is where the face-to-face service was performed, and that should be a place of service 11, or at least outpatient in your office, or it could be at home, but it's not subject to a telemedicine service. And if a beneficiary is readmitted to the hospital as an inpatient during that 30-day period, you can still bill transitional care services as long as all of the criteria are met to report the services and it's not attributed to that readmission. And then if the patient dies or expires before that 30-day time period ends, can you still report the TCM? You cannot, but you can go back and bill for that face-to-face in the first 7 or 14 days. Yeah, Medicare is pretty clear. And that's another reason, I guess, why not to bill it until the end, is because what if you went ahead and followed that Q&A on Medicare? So you saw the patient 10 days after they were discharged. So you fulfilled the, within 14 days, it was a moderate patient, but let's just say they expired, let's say on the 21st day, but you already billed it on the 14th day. You'd have to refund that money and go back and try to bill for an E&M service. And that can be a real problem. A question comes out about, what about the business days? How does that work? So if a beneficiary is discharged at 5 p.m. on Monday night, does Monday count as the first business day and then Tuesday is the second business day, meaning that the communication with the patient and or caregiver and response needs to be completed by Tuesday, end of business day, or can they wait until Wednesday? So in this scenario, the practitioner must communicate with the patient and or caregiver by the end of the day on Wednesday, so the second day following discharge. And then can TCM services be billed when provided in the outpatient setting? Technically, they can. Just remember, the place of service for the physician coding the service is where the required face-to-face visit is performed. And sometimes if it's the same POS as the TCM, you're going to have a payer maybe push back. And then really, are these services worth billing for based on the administrative work and the staffing necessary to fulfill the documentation requirement and the staff time? Because I get a lot of practices saying, well, my nurse is doing it. I'm like, okay, is it your advanced practice nurse or your nurse practitioner or clinical nurse specialist? It cannot be your RN or your medical assistant or your LVN, LPN. It has to be somebody who can bill directly to Medicare. They call them qualified healthcare professionals. I had one client that wanted to use their clinic pharmacist, which in chronic care management services, that can be part of a team member. But as far as their reciprocal 2-day call, no, that cannot be a pharmacist. They're only going to talk to them about medicine reconciliation. If the patient has questions or concerns about their overall care, the pharmacist isn't going to address that or talk to them about that. That's a physician or mid-level provider. So just keep in mind when you're looking at this as a potential revenue opportunity, make sure you know how much it's going to cost you and analyze that before you jump into it. Because if you look at, are these services worth billing for, it's really relative to your overhead in the office. And it has been suggested that this may be a primary care service, again, versus a specialty physician office service or option. So the 99495, that is the 14 days, that's allowable at approximately $154.06. And the 99496 for the 7 days you have to see them in the office is a $217 approximate allowable. So you have to think about it this way. If the discharge planner at the hospital is handling these services and you're going to see them and follow up within 2 weeks anyway, and you're going to bill out an office visit code, how much is that service? Is it going to be $150 versus $200? Or is it in post-op? What is it? Because if you aren't going to be doing all of that administrative work and coordination of care, and you're going to have them come back in anyway, then why bill this service? But if you aren't going to have them come back in, and it's something that you want to take on to make sure that it's appropriate and the patient really has nobody to help them with this service, and the coordination of their benefits and making sure they're making all their appointments and getting their prescriptions, then it is something that you could provide for them and in effect get paid for. But again, make sure you have to bring them in the office and evaluate them for why they were in the hospital. So I'd like to go over my coding question today. And this is an orthopedic question, and it's kind of interesting. It says, Terry, we'd like to explore the possible hip injection billing, and we might do it self-pay. The doctor mentioned there's a debate of which code that we can bill for, and actually this is an ASC client I have. So they gave me the codes 20610, which is a joint injection, 77002, looking at fluoro, or 27095, and 73525, which is an S&I code of another injection. But the thing is you have to make sure you know what setting and everything. So when you look at the 27095, for example, the codes for arthrography, meaning it's a diagnostic injection, and then the 73525, that's the interpretation of the arthrogram, not fluoro. Also, the primary code of this 27095 includes anesthesia. And so either one could be appropriate, but the biggest thing that I would say on that coding question was that many payers will not pay for these services in an ASC, only in the office. But if you're trying to do a self-pay injection, then you just have to set up a certain protocol and pricing list as far as what the self-pay patients are going to pay. But remember, if it is a patient who has a payer that you are a either preferred provider for or a contract provider for, or it's Medicare, they do pay for injections in the hip. And so trying to set up something that's cash pay when it is something that's paid for, you just need to know the schedule and frequency they'll allow. You're going to have a hard time getting that as a self-pay. So just be aware of that and make sure you're looking at all of their criteria to be able to code for those services. Our coding question was brought to you today by HealthTech S3, Strategy, Solutions, Support, Brentwood, Tennessee, working to put an end to opioid use disorder one patient at a time. Before I get to my personal tidbit today, I know that we've had quite a bit of buzz about my hierarchical chronic condition coding, the HCC 4-part series I have on my website. You may want to take a look at that as far as joining it either on demand or live, only because I'm getting a lot of requests, or I should say my clients are sending me a lot of inquiries saying, hey, Medicare just sent us a letter saying that We are being audited for a risk adjustment audit, meaning that the Medicare Advantage plans are now taking a look at you based on the fact that you build certain chronic conditions. You probably got a high score, and then they were seen either in a facility setting or by other physicians that did not code it the same way you did. And now there's a discrepancy in why your patient coded so high, but they didn't code that high with another physician. And remember, what this risk adjustment does, what the HCCs do, is they basically, for capitated plans, it says this is how sick the patient will potentially get. And so they price it out saying that this is how much money we've kind of put aside or put in a pot for this patient. And it's really variable based on how you're coding. And so just take a look at that Part 4 series. I just put up a brand new brochure that tells you, we had it on a blog on my blog site, and it's still there, but it's also, if you go to the webinar site, click on more information to the right, and you'll see each day, or I should say each part, what we're going to cover for each part of that webinar. And there's CEUs available for Part 1 through 4. But it'll just kind of give you an understanding from a basic to intermediate standpoint what you're doing with your coding. It's beyond ICD-10. It's beyond, just understanding how to code diagnoses. You are basically putting the patient's livelihood in your hands and their future as far as how much treatment they're going to be able to get from a Medicare Advantage plan perspective. And so HCCs are just so important to be as accurate as you can. So just take a look at that, and hopefully that will give you some insight if it's something you should participate in. So my personal tidbit this week, some of you have asked me, hey, Terry, where are you on social media? Well, I'm everywhere, but I don't like Facebook, but I'm on Facebook, but it's under Terry Fletcher Consulting. I don't post there very often, but sometimes you can find things up there and discounts on webinars and just some anecdotes that I put up there that I think are kind of amusing. And then I'm also on Twitter, TerryCoder1, and so I do like my Twitter. If you're a football fan or a sports fan, you can always find me on my other Twitter handle, which is Terry in CALIF, Calif, so short for California. And then I'm on Instagram, Terry in CA, and just know I post a lot about wine, a lot about my daughter, but also a lot of things about the CodeCast, a lot of things about some things that are coming up, social events, business events, and just some fun things when I have a thought during the day. So if you're interested in that, check me out on social media. And I know some of you, have reached out and said hi, and I appreciate that. So when you get a chance, check me out on social media. Okay, so a couple of things I wanted to mention, and this was something that I mentioned last week that I was going to give you, since last month was basically the stress awareness month. So a couple of things I just want you to keep in mind as you are doing your job throughout the day, and hopefully this will help you when you feel like you could be losing your mind throughout the day. I know that I feel that way every once in a while. So first of all, make a list. Make a list. There's an internet meme that says, the biggest lie I tell myself is I don't have to write it down. I make a lot of lists, lots of them. At least the list takes some pressure off because I don't have to clutter my head with remembering things. So I don't need to worry about them right this second, but I also love crossing off my list. So make a to-do list each day. Try to do it right before you leave work or right before you go to sleep, and your sleep will be more restful if you can make those lists and just really follow them the next day. You'll open up and go, oh yeah, I have to do that. And then work when you're the most efficient. I know that's a tough thing to do, but many healthcare professionals work from home now, or at least you have the option to be remote part of the time, which means you can usually make your own hours. But if you're most efficient at 5 a.m. when the rest of your family's sleeping and the world is asleep, talk to your supervisor and say, can I flex at least one day so that I can come in at 5 o'clock or 5:30 in the morning and then be done by 2:30, 3 o'clock in the afternoon? And that way you can go to the grocery store, make your appointments, and then deal with your kids or your family after you've had that a couple hours time at the end of your day where you're not rushing home to the chaos. Believe me, I know how that feels. And then surround yourself with people who know your limits. When I worked for a large surgical group years and years ago, my immediate supervisor at work was often my conscience. She knew that I would do almost anything I needed to do, even if I didn't have time to do it. And she's the one that put the focus on in my head of focus on the sustainable, what you can get done. And so make sure that you're trying not to be the everything to everyone, to the employer. And sometimes you're going to have to just say no. I know it's a hard lesson. It's one that I live with every day, but sometimes you just have to say not now. Okay. And that'll make you at least a little bit less stressed about what you have to get done. And then next, I know everybody says, oh, go for a walk during your day. You know what? If you just can't get out to go for a walk, take a window break. Find a window, leave your desk space, and look out of that window for just 10 minutes. You're allowed to have a break. That is in every state or country. It will relax your eyes and your mind. And don't pick up your phone or electronic devices to get on social media when you go to that window. Focus on trees. Focus on something of nature. Just look outside. Focus on the clouds. There's a thing that happens on Twitter a lot where they say that the cloud challenge. Have you ever looked up? I always tell people, don't forget to look up. I just put that on LinkedIn recently. You know, sometimes it's fun just to say, what are the clouds trying to tell us? Just look up and try to give yourself that break from the artificial stimulation. That is your meditation moment, and just breathe for a second. I know that's hard to do, but try it. And then separate your home and workspace if you can. That's a big one. I know that some of you who are working from home or take work home, the one great thing about working from home is that you can work from home anytime you want. The one bad thing is that you can work anytime you want. And so setting boundaries is important. Try to make sure you have some boundaries set. Otherwise, you could find yourself heading to burnout before you even know. And then the best career advice I could give anybody, and I'm going to kind of end on this today, follow your bliss. And I'm not saying, you know, the sun on your face, wind through your hair, you're on the beach somewhere. Well, I'm kind of saying that. But the best career advice, seriously, is don't follow the money or pathway someone thinks you should. Find your niche. Find what you love to do and find the job that fits that. Now, realize that businesses evolve. And there may come a time when your bliss doesn't align with your company's organizational goals. And so you're going to have to decide what you want to do at that point. But people say all the time, life is short. People, life is long. Do not stay in a position that you do not like, that sucks the life out of you, or that you feel stuck in. The job market and healthcare is awesome right now. So find what you like to do. Do you like to audit? Do you like to code? Are you a biller at heart? Do you want to go back to the front desk and see people? What do you like to do? But find your bliss and follow your bliss into your profession, and that'll make you happy. Okay, everyone, thank you for joining me this week. Everyone, make it a great day, and we'll talk to you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.